My name is Martha Perry. I did an adolescent medicine fellowship at UCSF and actually completed the last 6 months of it in Boston, having been a pediatrics resident there, and then came back to finish up fellowship when my husband decided to change coasts for his job, and then worked in academics for a while, and then went into private practice, mainly to have more structured time at work as well as at home with my kids. And it's actually been a fabulous experience to learn how to provide efficient and effective adolescent care in a managed care environment. So part of why they asked me to speak today was to talk about some of the challenges that we come up with, some of the strategies that we use. And I don't have all the answers, but I definitely have thoughts and ideas, and also welcome your thoughts and ideas as well. Just to kind of think about why I said adolescent friendly, my philosophy is that adolescence is a complex time where the provider-patient relationship is really challenged because of the occurrence of multiple biopsychosocial changes, experimental and risky behaviors that are occurring, parental or family conflict, peer influences, social media influences. All of this complicates our relationship with them. They need a listening ear that they can trust to keep it confidential, and that doesn't pass judgment or lecture them. This is something all of you know because you're here today listening to this. Parental involvement may be warranted. In fact, I often encourage it, and it's often very helpful. But the adolescent has to help determine what the extent of involvement is. What I'm going to do is review consent and confidentiality as it pertains to standard of care for adolescents. I'm going to talk about some of the approaches that we take in the again, managed care setting, but is relevant to any adolescent clinic in terms of maintaining their privacy and providing a safe place for them to come to get all of their concerns addressed in a sensitive way. I'm going to talk a bit about charting and some of the systems that we can use, or some of the things to keep in mind to prevent stigmatization as well as to prevent breach of confidentiality. I'll have examples, but also welcome you to have examples as well. Raise your hands, make this an interactive discussion. That makes it more interesting for all of us because we all have stories. And we'll talk a bit about billing to ensure adequate reimbursement and also to ensure confidentiality. Just as a little bit of background, 76% of adolescents in one study wanted confidential care, but only 45% actually thought that their clinician could or would provide it, and only 28% reported their provider actually discussed it directly with them. So that's basically about a quarter or less than a third of patients have actually been told about confidentiality by a provider in this particular survey. Confidentiality is particularly relevant with sexual health care, which is a lot of what we're talking about today. And in a survey of Title X clinics, 59% of girls receiving contraceptive services said they would not come if it was not confidential. And of course, not surprisingly, only a small percentage, 1% of them, would actually change their sexual activity related to that. 35% of students surveyed said they have not sought care because they don't want their parents to know. So adolescents are more willing to communicate with and seek health care from physicians who assure confidentiality, and adolescents are more likely to discuss particularly sensitive topics if they are proactively instructed by their provider around confidentiality. One of the things that I think a lot of people assume that adolescents understand consent and confidentiality, or assume that parents understand. A lot of parents are surprised when I tell them there are certain things your child can consent to without your knowledge. And I will go over that, whether it's relevant to the patient or not, at some of the initial visits, because I want them to know that their child can consent to reproductive health care in our clinic. Their child can consent to mental health services, or can consent to certain mental health services, can consent to substance abuse services, and also that they can discuss these issues with me, and then I'm not going to share that information. When surveyed, no more than half reported most MDs would provide confidential information. And even after conditional assurance of confidentiality, only 28 to 36% really believed they would get confidential STD care. And that's a big problem. I've definitely had patients who say, I know you tell me it's confidential, but there are so many different ways that my parents can find out. And so, sometimes we'll have an agreement about what I write in the chart or don't write in the chart, and we'll talk about charting and how to get around that. But it gets complicated. The conditional assurance of confidentiality is also really important. So many adolescents don't know, they know they have confidentiality, but they don't know the exact conditions around it, and that we do need to at times reveal information if they're in danger. So this is a statement that Carol Ford wrote that is just sort of a narrative that can be used. And oftentimes what I'll say is, with the parent and child together, I will say everything that we talk about once you leave the room that pertains to sex, drugs, alcohol, tobacco, feelings, etc., I cannot discuss with your parent. You can discuss it with your parent, and I encourage you to. I think that's very important, but I can't discuss it with them. In fact, it's actually against the law for me to discuss it with them. More importantly, I respect your privacy, and that's why I wouldn't discuss it. And I leave it to you to choose what you're going to discuss. But I need you and your mom or dad or whoever's there to know that prior to us entering into this discussion, and for people to acknowledge that. I've only had one parent actually refuse to leave the room when, in my private practice setting, to refuse to leave the room when I've gone over this. And she actually recently switched practices because she was upset that I asked her daughter about gender preference, because I still went through all the questions in her presence. How many of you have had objections to confidentiality for your patients? And what kind of examples? Give me your examples. What happened in those situations?
Well, I was in the ER, and then one of the mom, it was a 14-year-old girl who came for burning urination. Mom thought it was UTI. I ended up checking for chlamydia and burning because I had that confidential question with her. And then, I asked mom to step out and I asked all those questions. So mom came back and she was asking what treatment I was giving for, and she wanted to know when the girl was working, or, She started arguing, this is my little girl, and we are saying that, it's not UTI or something else.
Mm-hmm. Yeah, and it's very hard because then you run into, do you tell that you can't really give the parents an accurate diagnosis, or you can't tell them the truth, but then if you can't tell them, then they assume it's something bad. And so sometimes I will counsel with the patient means to be able to tell their parents. And many times I'm actually able to convince them to tell their parents what they've been diagnosed with. I often find that's what goes best, or ideally. I don't obviously coerce them into that. I just say, you know what, I think they're probably going to find out about this, so let's figure out how to tell them. Do we want to tell them together, or how do you want to do it? And in certain situations like that, where everyone's right there and they want answers, it's harder. We used to run into that a lot in the ER as well when we had consults when I was an adolescent fellow at UCSF, and generally we would just use very non-specific terms. We'd say, oh yeah, they have an infection in their urine and we need to give some medicine to clear it up. And sometimes parents would accept that. More savvy parents or parents who are in the medical profession wouldn't accept that. And that's where there's only so much you can do as a provider to guarantee the confidentiality, but I think that it is okay to stretch the truth in terms of what you're actually treating. What other examples?
I work in a psychiatric setting, so we get patients who are engaging in binge purging or cutting, or they might be very impulsive and very risk-taking. I mean, is that considered, if you have a 14, 15-year-old, is that something to let the parents know that the person is engaging in behaviors that are essentially self-harming? I mean, how do you define what's harming to the person? That's so broad or so
narrow. And we'll get to that. I think that it's, one, it's important that you develop that you have a policy at hand that's in your office, which is what it sort of is mentioned on this slide, and that you're clear with it from the beginning with the patient and the parent, so that you're discussing with them what you're going to share and what you're not going to share. And so it's really about weighing what the rights of the patient are and what the rights of the parent are, and obviously you want to protect that young person and take care of them, and they may not be able to make very good decisions. They're thinking with their amygdala, the rest of us are operating with our frontal lobe, and so how much independence do we give them? But at the same time, they do have a desire to make their own decisions, and sometimes it's it's the best for them in terms of their developmental stage or in terms of their safety at home or their recovery from their disease, that information is not shared. So what I recommend is that it has to be justified. So it has to be something that's life-threatening, something that's serious chemical dependence, where, again, that their life might be in danger, or suicidal or homicidal ideation. I don't consider cutting suicidal behavior. I consider it a sign of stress and concern, and I express that to my patients, and I encourage them to share it with patients, and often parents have already noticed it or are aware of it.
That patients would get 15 stitches. It's really
right, and so that becomes more, more towards a more significant harm to self. But again, I would argue that's not life-threatening. I think that if the intention was to take their life, which is important in terms of figuring out the intent, then it is something that you would want to share with the parents. And it should always be a discussion with the adolescent. As we talked about, I will say to them, I'm very concerned about your behaviors. You've been water loading every visit. I told you not to water load this time. You lost 6 pounds. I need your parents to know that. And they don't want their parents to know that, but I need them to know because we need to change your level of care, or we need to alter your treatment plan in some way. And oftentimes, I believe that most of the time we should be meeting with parents and adolescents together, that those are times when I bring the parent I talk to the adolescent, we do a sort of, I repeat to them what I'm going to talk to the parent about, and I will talk to the parent separately. Because what I'm going to try to do is stop the parent's reaction that will negatively affect the outcome. So I don't want the adolescent to think I'm in the other room talking about something that they don't want their parent to know. So I say, here's what I'm going to say to your parent. I'm writing it down. This is an outline of what I'm going to say. And I go and I talk to the parent about it. And I say, this is what Susan and I decided that we were going to talk to you about, and we really want you to know. And what I do is help them gauge their reaction. So they'll often say things that I do not want their child to hear. And so I don't want to announce certain things to them until they've heard it, they've processed it with me. This takes a lot of time in the office, but then we go back, and we'll get to billing on time later. And then I'll go back in the room and I'll repeat it with both of them present. So I'll say, this is what I told your mom. Do you have anything else you want to add? And I'll let the parents we'll rehearse even together about how they're going to respond to it and what they're going to say. So I find that's often helpful, and most times I'm able to convince the patients to share what's necessary to allow them to get the level of care that they need. Again, we kind of went over this already, but just explaining what you're going to say to the parent is key, and letting them know that you really do respect their privacy, that yes, it's against the law. I'll say to the patients, you could sue me if I reveal confidential information. And they always think that's kind of funny. And I say, I'm not doing this because I'm not keeping this confidential because I'm afraid you're going to sue me. I'm doing it because I respect your privacy and your right to privacy. But I want you to know that is a law, because sometimes other people don't respect that, and you need to know that. In terms of who's entitled to confidential services and which ones, what states are people from here? Massachusetts, Rhode Island, anywhere else? Connecticut? Oh, that's right. Connecticut's actually fairly progressive in terms of some of the recent changes on EOBs, which I'll get to. But all minors, according to federal law, are entitled to consent for family planning services other than abortion in certain states. In Title X clinics or by Medicaid providers. Every state has its own statutes that allows minors to consent to certain things. So are people aware of what they can consent to? Pretty comfortable with that?
I'm not. Can you go over that?
Sure. So which state are you in? Rhode Island. So I know the Massachusetts ones, but to find out what your minor consent laws are, there's a variety of different ways. The easiest way, and there's a slide at the end of this, and this slide will be available online, that gives some websites, but the Center for Adolescent Health and the Law is really the best resource that summarizes and regularly updates consent and confidentiality by state.
I can actually answer it. So adolescents here can consent to substance abuse or mental health treatment. They can consent to STD treatment. They can't actually consent, or without parental notification, to contraception or prenatal care.
They cannot.
They cannot. And then they Pregnancy. So it's kind of de facto in Rhode Island because actually you can, the way that the laws are written, you can choose to fall. I would feel protected, by the laws to practice however I see fit, as far as confidentiality goes. But because Rhode Island is a small state, the hospitals, or particularly the ones in Providence, all kind of practice this idea of kind of what they're most comfortable with, in terms of where any kind of repercussions could happen. So in that sense, it's de facto that you can't give information about contraception or distribute contraception or pregnancy, prenatal care without parental notification. That doesn't mean they have to be in the room, but like you would need to get you'd have to let them know, get a letter from them or something saying it was okay.
To either provide contraception
right.
or talk about contraception.
Yes. And then you have to have parental permission. This might be similar to other states for abortion or adoption. Like the adolescent can't consent to that.
There are very few states where an adolescent can consent to abortion without parental consent. California is one. Most states have not most, but several states have a relatively easy way to bypass the parental consent, going before a judge in an expedited way, like Massachusetts. As I said, because it's a federal law, technically most states are supposed to be able to provide Title X contraceptive or reproductive health services other than abortion.
But that would be in Title X centers, right?
Correct.
Not any place
right.
else in the
Well,
country.
and participating Medicaid providers. So that means, for instance, my clinic, which is a private practice, but we have Medicaid patients, technically, that we fall under that. In terms of age cutoffs, that is one thing that's important to know. There's no age limit for reproductive health care consent. So any age child or adolescent can receive reproductive health care in the state of Massachusetts. There's no definition of age. This doesn't start at 12 or whatever. There's no specified age.
Is that the way the law is phrased, reproductive health care?
I'm trying to remember. I just literally was reading it 2 days ago. It's healthcare related to reproduction and sexually transmitted infection or something along those lines. That's not the exact wording, but it specifies both of those. I think maybe it's sexual health might be a better way of describing it, because the reproductive health would technically include abortion, and that's obviously not included in Massachusetts. The other important thing is that for mental health and substance abuse, there are age cutoffs. So are you guys aware of the age cutoffs for consent in Massachusetts? So I kind of don't follow these, but technically it's age 16 for substance abuse treatment facilities to be able to consent and to have right to confidentiality, and it's 15 for mental health. So that's actually what's written in the laws. I don't think that people follow that generally. I think that we assume that it's confidential, but technically, if someone was going to really push the issue, there are specific age cutoffs for those two areas. In terms of minors being able to consent to any sort of service, you can declare them an emancipated minor. And the way that you can declare them emancipated minor, which is kind of interesting, is by declaring that there is an intended pregnancy or that they're seeking care related to pregnancy. So some lawyers will get around that loophole to basically say they can consent for anything without parental consent because you're defining them as an emancipated minor. And the definition of emancipated minor can sometimes be loosely worded to allow that.
I thought Massachusetts didn't have an emancipated minor statute per se.
They do for regular medical care. So for the specific areas we're talking about, for confidential care, they don't. But for just regular medical care, they do. So it gets confusing because our lawyer, for instance, we just had a case recently of a young woman who was raped and came in for care. I wasn't the one who took care of her, but the provider did a variety of different STD tests, including HIV. She was 17. She signed consent. It went to the lab. Everything was set. She went to a rape crisis center. They called and they asked us to fax over the lab results. We needed consent, so the mother was called. or no, the mother called actually, I'm sorry, from the Rape Crisis Center and said, I'm here with my daughter, she's been raped, they need the information. Can we have the results faxed over? They said, we need a consent. The mother signed a consent, they faxed over the results. What's wrong with that?
HIV test?
Yeah.
She's the only one who can consent.
Right, so the minor is the only one that can consent for that to be faxed. And not only that, you can't fax HIV test results. Yeah, so there were two things that were wrong with that. And there was a very, very nice administrative person on the other line who was really trying to be helpful because the mom was desperate at the Rape Crisis Center. I need this right away. You know, can you do this for us? The daughter was right there, but technically that's a breach of confidentiality and consent. But what's interesting is that when it got brought to our risk management, our lawyer, he said that in order to do the HIV test, that we had to document in the chart in some capacity that the child was an emancipated minor. So that's how I ended up investigating, this is just happening this past week, more thoroughly emancipated minor regulations. And you do not need to document that for anything that's sexual health related, mental health related, or substance abuse related. But for other medical care, like, you know, a sore throat or whatever, you're technically supposed to. We do it all the time. We have adolescents walk in and we swab their throat. We don't talk to the parents. We send them home. But technically, they're supposed to be in some way emancipated in order to consent for that care, which is interesting. The other interesting thing is that there's a lot of different regulations in terms of sharing information. So, for instance, in terms of the HIPAA rules, that technically provides protection as well to the adolescent, so that technically we're not supposed to release even minors' health information if it's protected in some way by a confidentiality law. So in addition to the person who sent over the HIV test when it wasn't consented properly and it was faxed and it shouldn't have been faxed because you're not supposed to fax HIV results, it was also technically a HIPAA violation, which isn't a big thing except that you can get a hefty fine with that. In terms of consent and confidentiality, the biggest thing that comes up a lot is EOBs, so explanation of benefits, when we're dealing with the managed care companies. How many people have run into that as an issue? So tell me more about that. So you've had a managed care company that sent an explanation of benefits, and the parents have objected to it, or tell me the scenario.
It's basically in terms of counseling, like the adolescent, like I have to, because of the way our practice runs or because of the insurance that they have, I have to learn them that, you know, I'm willing to give you this, but you have to be aware that your parents could receive word about it because of these notifications can be sent to them.
Okay. So interestingly, now, if it's related to sensitive information, most managed care organizations actually don't send an explanation of benefits. And now they actually are not there. They used to be required to.
Martha, you're talking about insurances in general?
Yeah.
All insurances?
Yes. Yes. They don't. They know. So they often do not send an explanation of benefits related to a sensitive service visit. It's a common misconception, at least in the state of Massachusetts. For example, big institutions like Blue Cross, if a patient comes in and they get diagnosed with an STD and they get a pregnancy test, the parents are not going to get an explanation of benefits.
So is that recent? I mean,
that is relatively recent. The other thing, though, is that what's definitely been now mandated is that if they do send an explanation of benefits, if it involves sensitive services, they cannot put those codes on there. So I'll give you an example. A few years ago, before insurance companies got a little bit better about sending EOBs, so they're not sending them as often as they were, a few years ago, I had a patient who came in, had a chlamydia test. It was positive. We treated him in the office, and he went home, and he got an explanation of benefits. And his mom was a nurse, and she looked at the code on there, because it didn't say much. It said lab test, and it had the code for the lab test. And she looked it up in one of her books and said, "What were you doing getting a chlamydia test?" And it created, all sorts of drama. But so the issue is that now they cannot put on those, it's actually mandated that they can't put on those sensitive service codes. Now, what they define as a sensitive service code is a big issue. But for instance, certainly for lab tests, which is actually what I find to be the major issue as opposed to diagnosis, generally that is where it's most important.
So
Because
they wouldn't do pregnancy tests or STD tests presumably?
Correct. Correct. They'll either not put it on, which is what a lot of EOBs are opting to do, or they'll put on just tests without any other information, and they'll put the charge and they'll put the reimbursement rate. I find that parents, even if they do get an explanation of benefits, if everything's been paid, they don't tend to object.
So, do you have any sense, Martha, of why that happened? Why that shift happened?
Yes, because a lot of organizations came together and lobbied for that. The main organization, which I'll give you the website for at the end, which has a summary related to EOBs. But do you have more information? Is that why you're asking? Or no? Yeah. So they're at the very end, and I always mess up their name, so I'll tell you at the end because it's on a slide. But they actually came forward and lobbied for it, and it's now mandated that they cannot put that information on an EOB. They can still send an EOB, but they can't put that information on there.
I actually saw a patient, or heard about a patient of one of the other people in our division who she had done a drug screen on the patients, and mother got that, and it was not paid for. Or actually it was paid for, but it was really expensive, like $450, and she had 2 kids. And she said one of them had been tested, and she said that one wouldn't be using drugs at all, and that it was the other one who should have been tested.
Oh, that's interesting.
So she was just saying, I don't object to testing, but I think that
You tested the wrong
you got
one.
this wrong. And then she was just saying, and it's so expensive, even though it's paid for by my insurance company. I know that that's driving the cost of care up.
Yes. Yes. So when they get a summary, even when it's paid for, when they get a summary of how much it costs, they get very upset. I've had that actually happen with consult codes, because for some visits I'll code as a consult, and it can be more expensive for a visit than a regular routine visit with a primary care doctor, and we get calls about that. Like, why did this cost $400 when the regular physical costs $250 or whatever?
But now Blue Cross Blue Shield doesn't accept consults.
Correct, and we'll talk about that. Yeah, not just Blue Cross Blue Shield. The list is getting longer. Tufts is not accepting them. Medicaid is not reimbursing for them. There's actually not that many. I mean, we'll still use them, but I think it's going to be out. Sorry, you keep raising.
Yeah, no, I think what happens with us, I get a lot of calls from college students who don't want their parents to know that they're getting treatment for their eating disorder. The name of our facility is Cambridge Eating Disorder Center. So, and what I have told them, I said, I can't guarantee they're not going to get it. I would want you to call the insurance company to see if they can send the EOBs to you and not to the household. Is that
That
could you
is
do
something
that?
that you can do. If you call an insurance company and say it's going to endanger you if the EOB is sent to the carrier, they will send it to where you ask it to be sent. If there's money owed or things not reimbursed, it will be sent to the carrier. It will not be sent to the patient. But if it's just an explanation of benefits, there's not a bill involved, they're not asking you for money, they'll send it to the person who receives the care. So I got off on a little bit of a tangent with EOBs, and we'll talk more about EOBs, we'll talk more about coding, we'll talk more about charting. I want us to talk a little bit more about other concerns other than confidentiality that prevent adolescents from coming in the office, because part of what I wanted to cover was just what kinds of things we can do to make the office more welcoming to them. And again, I welcome your comments, and we'll keep it moving as best we can. Obstacles to testing for chlamydia, which were well studied in 2003, reveal the fear of discovering that they have an STD, so just not wanting to know, a fear of AIDS. In fact, a lot of times when I ask patients, do you know why we ask you about sexual activity? Well, yeah, because of AIDS. And a lot of times that's not the top thing on my list that I'm worried about. So it's important, I think, to not that I want to dispel a fear of AIDS, but I want to just make sure they understand what they really should be fearing in terms of other STDs and possibility of pregnancy or other concerns. Some have false conceptions about what chlamydia could do. And then other obstacles to STD care are the cost of it, which we've talked about a little bit, the transportation, office hours, office staff. So if you go into the office and someone says very loudly, "What are you here for?" "Oh, you're here for a chlamydia test?" So I think it's important to make sure that staff are trained, that they understand that the teen issues need to be kept confidential, that they're maybe using code words or they tell the patients over the phone to use those code words, that they're very clear on what the policy is around confidentiality. A lot of people are parents themselves, and they sort of feel like, if I were a parent, I would want to know about this, so they have trouble with the confidentiality policy. And sometimes they violate it just because as a parent, they feel conflicted about it. Or they just feel like they're doing the right thing. Not that they're calling up a parent and saying, your child's here for X, Y, and Z, but they're not as discreet in the waiting room or wherever, so other parents overhear or things like that. You know, the print in the office should be things that adolescents, this is all, you know, old news to you guys, but it really bothers me that in one of our exam rooms, we have the alphabet with Elmo on it. And we bring patients in there because we're a pediatric and an adolescent clinic. And so I'll often at least just point out to that and say, I'm sorry you're in the Elmo room today, because we have other exam rooms that are better, but I don't really want an adolescent sitting looking at the alphabet with Elmo on it. It's very effective for the younger kids, and it gives them something to do while they wait for us, but it's not so entertaining for our teenagers. And I do really try to keep things posted that were friendly to lesbian, gay, transgender, and bisexual youth. So having just, you know, the pink triangle sticker on the cabinets, or something that's posted that's clear that you're an accepting and open practice for youth of all genders, of all orientations and all ethnicities, et cetera. It's really important that it's communicated. And I think it's great to post something about confidentiality, because I find that as they're sitting in the room, parents will read that and they'll say, really? Is that true? And we'll ask about it. So these signs here are actually made by the Adolescent Health Working Group, which I think does a great job summarizing what you can do to make your practice more adolescent friendly. They're an organization based in California, and they actually provide you free toolkits you can download in PDF form, and it's a toolkit that kind of guides you through office setup, questionnaires, how to address particularly sensitive issues, how to ask about particularly sensitive issues. So definitely worth looking into if you're interested. The Adolescent Health Working Group, and the website's at the end of the talk. Again, just making sure that the teenagers have a place that they know is private is really important. We don't have after-school times for teenagers. We don't have weekends for teenagers. I think it would be fabulous if we did. Many of you probably do, I hope, because I think it's really important. What do you guys do about late arrivals for teenagers?
I usually just see them if they come.
Yeah, so it's a big debate in our practice, because our pediatric patients, we generally, if they're more than a certain amount of time late, we generally don't see them. We generally ask them to reschedule and come back. But for a lot of the teenage patients, a lot of times they're getting rides from people, or there's trouble coordinating things, or sometimes they didn't want to come and their parents forced them to come and they were late and they really need to be seen, and so if I tell them to come back, they might not come back because it was kind of hard to get them there in the first place. So I generally would see them, but then what I usually do is send out a letter when someone's coming to the adolescent clinic to say, welcome, here's how we do things, and one of the things that you should know is that you can oftentimes spend a long time at adolescent clinic. It takes a long time to talk to teenagers, and sometimes you have to wait. And it actually really helps people kind of be aware that, oh, I might wait for an hour. Let's bring our homework, let's bring some reading material, make sure you have a cell phone to play on. It makes a big difference that they know what to expect coming in. In terms of communicating, do you have a system for communicating with your teenage patients now?
I have a question about this because this comes up in our office, and it's a huge debate about, can you text, can you email, is it okay, is it HIPAA, and so I don't know the answer.
So yeah, so that's a good question. So in terms of email, it depends on if you have a secure email system, then it's technically not okay to email. That being said, I email unless you have a secure email system. That being said, I do email other providers about my patients, and we just use initials for their name, because otherwise we would have a hard time keeping up. When you have an eating disorder patient that has a nutritionist and a caseworker at CEDC and a therapist and a psychiatrist sometimes and a family therapist, having an email communication, I think, really improves the quality of their care. And we do have secure email, although not all the email addresses that I'm using are particularly secure. So I'm very careful about what information that I share. And so technically, in terms of HIPAA, if you're not sharing any personal health information, so you're not sharing their date of birth, you're not giving their name, their address, you're not giving their social security number, I think you could argue that you can share that you can have those email exchanges. But don't quote me on that. You need to ask the HIPAA lawyer for sure. But that's my very basic understanding of that. In terms of texting, a lot of places are doing it. There's actually a couple websites that have information about it. One is called Texting in the City, and another one is called Mobile Health. And so there are various organizations that are doing work with this. We're not allowed to text in my organization. It's not considered secure. In terms of appointment reminders, what do people do for appointment reminders for their adolescents? Do you guys call and remind them? And when you do, who do you call?
They call the house. There's a system that they call a couple of days before, right?
Yeah, we used to not do this at all except for routine health visits that had been made, but there were so many no-shows and so on in our population that it was decided that we can simply call and say we have an appointment. So it's not complete confidentiality.
Right. So and we run into that too. We don't, when they make an initial appointment, we don't do a reminder call. If they miss the appointment, we actually notify their primary care provider that they missed the appointment, because then oftentimes if the primary care caller is calling as opposed to the adolescent clinic, it's not as much of a red flag for the parents, so we ask them to do it in our organization. Once they come in, we actually get this, we ask for, it's a procedure that they go through, we ask for the patient's cell phone number. And then we ask a series of questions. Is it okay to call your number? Is it okay to leave a message on your number? Is it okay to call your house with an appointment? And those questions are posted in a particular section of the electronic medical record, so whoever's doing the callbacks accesses that and calls. Now, if you have an automated system, that gets more complicated. And we do have an automated system, but our adolescents don't get put into the automated system. We have someone who does it by hand.
Do you just see consults, or you just
When you
go to
say
receive?
the adolescent clinic, is that only consults, or you don't have primary care patients?
Not in adolescent clinic. I do have primary care adolescent patients, but in our consult clinic, it's just patients who are referred or patients of mine who are coming for specific adolescent issues. So predominantly eating disorders, substance abuse, depression, anxiety, ADHD, PCOS, lots of reproductive health care, and GYN issues. For routine, sorry, go ahead.
So you can refer to yourself from
No, I cannot refer to myself. But I'll see my patients just in the clinic because we're set up, and that way then they get tapped into some of the more confidential services. But I don't bill as a consult person for that.
For yourself.
That I cannot do. So I basically recommend that there be a standard way to contact the patient, that it be documented in a standard place in the chart, and that all the staff is aware of it. And it makes a huge difference, especially with calling back results. So we'll get my results electronically, and I'll say, please call back patient using number, and we have a family section in Epic, and that's where we document their cell phone number so the staff knows to do that. For a while, I had a problem. If they didn't find a cell phone number or they couldn't reach the cell phone number, they'd start tracking down and calling all the numbers. So we had a very angry grandmother call and say, why were you trying to get a hold of me, and what results are you talking about? And then they're saying, well, we can't release those results to you because they're confidential. And she's thinking, oh my God, she's pregnant. What am I going to do? It caused a lot of unrest. So we tell people, if you can't leave a message, just document that you can, let the provider know, which would be me, and if I think they need to be contacted, I will. But for negative chlamydias or negative tests, I'll often have the staff call, leave a message, but on the patient's cell phone.
Don't you run into the fact that most of our patients' cell phones have some long, loud rock music or hip-hop song on them and don't identify who it is on the phone?
Yes, we run into that a little bit. And so if we do, the standard is, this is Dedham Medical calling. Please give us a call back. That's all we say. We don't say for results or anything like that. Definitely, that comes up. In terms of when to start asking, in terms of the confidential questions, when do you guys usually start asking? Age 11, 12? It's around.
We start as soon as our patients come to Adolescent Clinic, which is usually 11. So occasionally
Most of the patients I'm seeing are probably 12, 13 in terms of who get referred directly to Adolescent Clinic for me, but in my primary care, usually I'll start asking when I'm seeing signs of puberty. or I'll ask about kind of what things are like in middle school, what kids are doing. You know, if they're a very, very immature 5th grader, I may not ask about sexual activity. But I think it's important to kind of assess the patient. I try to encourage providers to ask on every occasion. So if they're in urgent care, ask them. If they're in for an immunization, ask them. Check and see, are they due for a chlamydia test? Have they had one in the last year? There's some good studies that show that testing for chlamydia in the urgent care setting can really help reduce rates and improve testing rates, reduce rates of infection and improve testing rates. One of the things that I have learned is in terms of finding alone time with the patient. I don't know if you can read that, but it says, so would actually, can I read it? It says, so basically it says, so would you like me to tell your mother, or should I, that you're pregnant? And you have this mom sitting right on the other side of the curtain who's hearing the whole conversation. And I actually run into that a little bit when I ask parents to leave the room, that they'll stand by the door, and they have overheard some conversations. So now I am in the practice of, I open the door, I say you can go have a seat in the waiting room, I watch them walk away, and then I close the door. Because I would say it happens almost once a week that they try to stay, and they're not sometimes even trying to listen, but they can overhear. Our walls, unfortunately, are thinner than I'd like. I found that to be even more true in the academic setting, because sometimes they're just partitions or things. So I've definitely run into some near misses or some problems with parents overhearing. And as I talked about, I definitely explain, once the patient has left the room, I'll definitely explain again once the parent has left the room, I'll definitely explain again about confidentiality and ask them again, do you understand? Do you have any questions about it? As I said, I do send a letter ahead of time explaining confidentiality to adolescents, and I also explain what adolescent clinic is like, the weight, etc. The other big thing that I really believe in is that when I walk in the room, I focus on the adolescent. So I walk in, I shake their hand, I say hello, and then I turn to the parent and say, hi, how are you? And that's different from what we're used to doing in the pediatric setting. So I really make a big effort to do that and encourage a lot of the providers in the office to do that. And then I always try to ease into the situation, compliment the patient on something they're wearing or something about them, not their size, shape, hair, whatever, but I might say, oh, those are really neat sunglasses, or, oh, what book are you reading, or, something that kind of engages them, have a nice conversation with the patient about that before I move on to the more, sensitive stuff. These are probably obvious to you in terms of things to think about as you're asking confidential questions, but one of the things that I wanted to highlight is the sandwich method, which, are you guys familiar with that in terms of, so I'll usually, like I said, I'll say something positive, I'll praise them for a positive risky, something that they've done that reduces their risk. I'll talk about the risk and my concern about the risk, and then I'll praise them again. I actually find this very effective with eating disorder patients because they come in, they've lost weight, they feel like they're a failure. So we'll talk about what's been good, we'll talk about what we need to fix, and then we'll talk about what's been good again. So they leave sort of motivated and kind of with their self-esteem up just a little bit. We talked about what to ask and when to ask it. Does anyone have any questions about that? I don't want to spend too much time on that. I think you guys got that down pretty well. In terms of communication too, I think this is preaching to the choir. Barriers in terms of history taking also not something I think that most of this audience necessarily needs to hear, but certainly you want to make sure you're asking questions that you feel comfortable hearing the answers to, that you're avoiding being judgmental. And eye contact is really important. Trying to determine whether the patient wants eye contact or doesn't want eye contact. So some patients don't want to make eye contact, and so you don't have to. I do find that patients are actually quite used to me typing on the computer and talking to them at the same time, and that they're okay with that, although I do tell them, I'm just making notes so I don't forget what we talk about. This is not, an email to your friend telling them everything you're saying, and they think that's hilarious. And just so that they know that this isn't just like I'm writing down all their personal information. If it's a really hot topic, intense, they're telling me they were sexually abused, I don't usually sit and type it in the computer while we're talking, but that's somewhat obvious.
I work a lot with a translator, and oftentimes my translators are known in the community and know my patients. So do you have any tips on kind of how to work around those?
I used to run into that a fair amount at Boston Medical Center too. And it is a hard issue. I usually try to just address it outright and discuss it directly with the translator and the patient altogether. You know, do you know each other? How do you know each other? And review confidentiality and review. It is against the law for this person to share anything out of this room. And if this person shares anything, he will be fired or she will be fired. I literally will say that.
Instructors are all really pretty carefully trained.
They are.
And everything, right?
They are.
But it's probably important for the patient. to know
Yes,
that.
yes, exactly. And I take care of a lot of my colleagues' children for some fairly sensitive issues, and it is challenging. And so I have that conversation with them too. Of, you know what, if your parent gets caught looking in your medical record, they will be fired. If I talk to them about things that are confidential, I will be fired. There are actually very strict policies at Dedham Medical about that in many institutions about who has access to which chart. And if there is a breach, it actually gets written up and publicized for the entire, it doesn't say the individual, but the event that occurred gets publicized for the entire organization in an email so that everybody knows what occurred and what the consequences were. It's taken very seriously, and I really make sure to tell the patients that because I don't want them feeling like they can't share, and I still think they probably don't always share everything when their parent works there, but I do hear a lot of stuff, so it must help some. If I hear a lot of stuff, I wonder what I'm not hearing, but so charting. Do you guys run into problems with confidential information getting released when charts are, yes. So what kinds of things have you done to try to alleviate that issue?
Sometimes we have a big, when it was a paper record, we had a big red stamp that said confidential, do not release without permission provided, that we stamped every page with.
Yep.
Since the electronic medical record, we really don't have that, but you can type in big letters at the top of the page, confidential.
And you have probably those phrases that you can pre-do, you know, so you can type in, oh, you don't? So in our electronic medical record, you can type in a brief code and a full statement that you've put together, a full phrase will be entered. It's very handy. So I use that. I have that actually standard that I can put on top of my charts. And I also actually have templates, and on the top of the templates, it says that there is confidential information.
We do templates, and we just have that.
Yeah.
Does your medical record department honor that though? I mean, I guess
Yes.
my concern
Yes,
is
they
that
do.
are they going to go through every page and look for
No, so what
notes that are marked?
so the way that they handle it, and this is where I tell people you should know what the policy is in your institution. It varies from institution to institution, and even from individual person in the medical records, whether they're aware of it and what they do with it. At Boston Medical Center, for instance, they were supposed to go through the record line by line and black out the confidential parts, copy it, and send it. In our institution, what they do is actually similar. If the patient is in the teenage range, they will actually contact the provider and say, one of your patients, there's been medical records requested. There's several charts where you say there's confidential information contained. What should we do? Should we release the record or not release the record? And sometimes I will say you can release pages that don't have confidential written on them, or sometimes I will say you can release it, but it has to go. I don't want a parent picking up the record and taking it somewhere else. And technically, they're actually really not supposed to be able to do that. So I usually tell them to just send it directly to a provider if needed, if I think they need that confidential information. If I don't think it's relevant, so I have a patient who's going to have their scoliosis checked, but oh, by the way, they've had multiple chlamydia infections, and they've requested the medical record for some odd reason, which has actually happened to me a few times, I don't send that. I tell them to take that information out. What happens for you guys?
We have no control over what they do.
I don't think our medical record department is very functional or
Yeah.
sensitive to this.
Yeah, in terms of state and federal guidelines, they should be. So technically, they're violating HIPAA if they release the information, and you could make a good argument. But if they release information that's considered confidential for the patient, technically that's a HIPAA violation for an adolescent who has confidential information that's released to someone other than them, which I didn't know, again, until doing research from this talk, because I thought it was more just the general, name, address.
Scenario would be the kid is gonna be 16, 17-year-old, and the mother is gonna go to medical record and request a copy of the medical record.
So if you have knowledge of that, if I have knowledge of that, I will say to the mother, the medical records are usually not released to parents because, we always have confidential information in there in it for a teenager. So it'd have to be released directly to the provider, or, you can get, pieces of the chart.
But that's in case we know, but
Right,
we don't
exactly.
always know.
But
The
if you
parents
don't know,
can go
it's a
directly
problem.
to medical record.
Right.
In fact, they often have to,
Yeah.
because they'll say they've made multiple requests to have their records sent to the provider, and it still hasn't happened.
Right.
And they are told you should go downstairs.
Right,
to
and
have
get it
the
and bring it
records.
yourself.
That's the only way.
And I used to find, again, at Boston Medical Center, a lot of times the reason it hadn't been sent was that there was confidential information in there, and it was in a big pile for someone to review, and someone hadn't gotten to it. The other thing that I will sometimes do, which is time consuming, but I'll say, you know what, rather than getting the record, why don't I just write a letter that summarizes? Of course, it's more time for us, but sometimes I will do that so that they have the pertinent information. But it is a very, it's a tough issue. The things that people will suggest is using abbreviations or sort of codes that you and your institution recognize, but nobody else would. Then again, I think that can compromise the patient's care because people need to know that these diagnoses have occurred. In terms of the amount of detail that you record, this is always an issue. So sometimes I will read charts and they'll be like, well, such and such cheated on such and such, and then the person did this, and then the person did that, and they've sort of like typed in every detail. I don't recommend doing that. I used to because I wanted to have all that detail so I'd remember it, but the problem is there are a lot of people who do read that chart who are going to be judgmental about that, or who might slip up and say something or things like that. So I don't recommend necessarily including all that information. I might make a quick note to say there were some issues with boyfriend and cheating or relationship problems, but as I said, I used to write the whole summary, but what I'm finding, and in some of the reading that I was doing and preparing from this talk and talking with Lydia Schreier, who did a lot of the slides, is that less is better, to document what you know, but not all those details about relationship drama. You can use a shadow chart, which is what we used to do in the days at UCSF when I was there. You would have thought, being near Silicon Valley, that we would have had medical records before everybody else, but in fact, we didn't. We had a shadow chart.
Legal under Jacob.
Yes.
So we're not allowed to.
Yes.
The Joint Commission on Hospitals.
And again, in some ways, there's certain information that all providers do need to know. What I struggle with is what people write in their problem lists. So I will see people put on the problem list high-risk sexual behavior. Well, that's different for everybody. And so people will use that as a screening code that will determine which STDs they use, but you can also just use screening for sexually transmitted infections, which is a little bit of a gentler code than writing high-risk sexual behavior or other similar things that you can use as a code. Because what happens is that you walk into the room, in the electronic record anyway, you pull up the chart, and there's a snapshot, at least in our system, where all their problems are listed, and all their medicines, and da-da-da. So right there, looking at the nurse who's doing the check-in, and the mom who's standing behind at the check-in for the routine checkup, sees high-risk sexual behavior. And I find, rather than the billing and the EOBs and all that stuff, that is how confidentiality gets violated, is what's written on the front of the chart. I also find that everybody has a different definition for high-risk sexual behavior. And so I've had providers who patient was young and had one sexual encounter. That was considered high-risk sexual behavior, so it was written as a problem. I saw the patient in the adolescent clinic. I saw that and I thought, oh geez, what's going on with this kid? And I find out she has one sexual partner. I mean, I'm not thrilled that a 14-year-old has one sexual partner, but come on, in terms of the realm of high-risk sexual behavior, this is a patient who's actually there seeking contraception. So I don't see anything that high risk that warrants it be on the front of the chart. But I used to see that at Boston Medical Center all the time, or when I was in the school-based health centers, the nurse practitioners there would actually code using high-risk sexual behavior as their code for screening for any STD. And so that's when I recommended switching it to screening for, it's universally going to be covered when you use the V code for screening for sexually transmitted infections, so use that if you're not already, which you probably are. The other thing is that, especially with the electronic medical records, there are various sections in the chart where you can put information. So you can document it in your visit, but if you have information that you want access to but you don't necessarily want anybody who opens the record to look at, there are certain places where you can document it. So for instance, in EPIC, we have a socio-demographic page or a social history page. And it's just a tab that you can go to and you can document free text, any information in there. And it's not something that pops up. You have to go look for it if you want that information. So if you want something that only you can find, there are ways in your various systems, they all have it, where you could document something, but that not everybody has to read it. Because there are certain things, for instance, a patient's orientation, I'm not going to remember it. I'm not going to put it in a problem list. I'm usually going to document prefers whichever gender or both or whatever in my note. But there are some people who say not to do that. I do, because I think it's important to know and to be sensitive. But I might forget, or I might not have documented the full scenario around it, and I want to be respectful in terms of knowing their history and not necessarily asking them the same questions every time, because I will, but then they say, well, last year I told you already, so I try to document it somewhere. Do you guys run into issues with that at all?
Well, we don't have EPIC number one, so we don't have such a.
Is there something like that? Because our people have not been able to tell us about anything like that when we've had these.
I'm pretty sure there is. I've definitely known people in the adolescent medicine world, like in the private practice group, this has come up a fair amount. And with Allscripts, there are some sections you may not be given access to it. So like our secretaries have access to some of the demographic information, and there is free texting even in there. Recently we were given access to that. So for instance, we can even adjust the cell phone number in there, which previously we couldn't.
In that yellow thing, in the FYI, that's where
there's not
the cell
unlimited
phone.
space in there. That's where
In the yellow.
Well, yeah, that's
Yeah,
where
the
everything's like
stickies,
cell
or that's
phones
people
and
call
stuff.
those the stickies,
But
the
I
yellow.
don't think there's unlimited space.
No,
in
it's
there.
very
It's a very small box.
And is that something that's hidden and you have to access it, or does it come up when you open the chart?
It comes up, well, I don't know if it's hidden too. You would have to access it. It's a
Yeah.
little yellow thing that it's not yellow until you populate it with something, but when it is yellow, if you click on it, we put our patient contact information in there, like how they would prefer to be contacted, their cell phone, the name of their therapist and psychiatrist
yes,
and so on.
yes.
But I don't know that it would have enough space to allow you to do
social information,
social
yeah.
history.
Yeah.
Probably the demographic information stuff is put in by the front desk people, and I don't think we do have access.
Yeah, it'd be interesting to see. You may, and you don't know it, and there's often a little area that you can designate. And as long as it's a departmental, everyone knows about it, I've seen it work actually quite well. More along the lines in terms of confidentiality is kind of getting into the billing. So there's a couple of things to think about, in terms of diagnoses and billing for diagnoses. As I mentioned, now most EOBs will not state the diagnosis. But if the patient is not insured, or temporarily their insurance has lapsed, or something comes up, where I run into problems is not so much the EOBs, but that a bill gets sent home from our institution with everything clearly written, that what was done, what was tested, and what they owe. And that's when I get very upset parents, because I'm billing them for something they didn't even know about. So one of the things that I do is I ask every patient if their parent knows they're there. And if they don't know they're there, then we have a specific procedure in our institution that prevents a bill from being sent home. And we actually eat the cost. But what doesn't happen is what the lab does with the billing. And again, sometimes the lab might not have the most current insurance information, but we do. And so again, the lab sends something home. So a couple of things that I've done to help alleviate this is, one is I talk to a lot of parents about how it's standard to test kids for pregnancy and standard to test kids for STDs regardless of sexual activity, that it's just part of standard of care. So if they see a bill coming home with that, don't panic. We do that all the time. I do that before I've talked to the adolescent alone and when both parents are in the room, just so that they kind of expect that. So then it's not a big surprise. The other is, billing based on symptoms rather than the diagnosis. This is both in terms of reimbursement as well as in terms of confidentiality. So if they have urethritis, I bill for dysuria. If they have chlamydia, I'll bill for any sort of symptom that's related to chlamydia. There are times when I can't always, if they're coming in for family planning, you can't bill for family planning anyway. So I usually have to bill for some menstrual irregularity or something like that. And the part of me that doesn't like that is that you're not giving a wholly accurate diagnosis, but I find if I search enough, I can usually find some sort of, well, sometimes I have a little vaginal itching. Okay, I've documented that, we've talked about it, that's the diagnosis that I'm going to use. So it also comes up with reimbursement in terms of mental health issues. So I see patients for ADHD, for depression, for anxiety. And I'll go through all the symptoms of depression or anxiety. And rather than billing for anxiety, I'll bill for restlessness, nervousness, fatigue, sleep problems, any sort of symptom related to that condition, as opposed to billing as a primary diagnosis depression or anxiety. And of course, the standard that often will get some reimbursement as opposed to depression or anxiety is adjustment reaction or adjustment disorder. The other reason that I oftentimes will use those diagnoses is that when I have them in the problem list, again, I want to make sure that whatever pops up in the problem list, I want it to be something that I don't care who sees it. So, sometimes, people will suspect a borderline personality disorder, and they'll document that in the problem, like borderline traits. Well, then, now actually patients have access to their problem list at home, and they go and they look at it, and they've been, what do you mean borderline traits? Or psychotic episode, and they were seen in the ER, and they had some weird episode, and it was called that, and the provider gets the note, and they put it in the problem list. But really, the patient never even knew that they had that, and it really upsets them when they see a diagnosis. Or anger management issues, or all sorts of things. So I've seen a lot of patients get quite angry now that they have access to their charts about what's listed as their problems. So I always tell people, you want to list what you would want people to see for yourself. So if you had depression and you want people to see depression, that's fine, but make sure it's clear to the patient that that's their diagnosis, and also make sure that if they have a substance abuse problem, that they know that you're documenting they have a substance abuse problem or whatever it may be. In terms of parents viewing the medical records along those lines, we have a separate login system for patients that view their records online. So the adolescent can view everything, the parent cannot. And I don't know if you guys have it where patients have access through patient portals yet. No. That will come up, and when it comes up in terms of relation to adolescents, it's something that I had to really get on our institution about giving them access but limiting parental access. And really being mindful of what's going to appear in terms of medications, in terms of problem lists, et cetera. With medications, if you treat them one time for Zithromax, one of the ways to get rid of it is to just put an expiration on it, so then it doesn't stay in the system. So that's what I try to do with anything that I don't want parents to know about.
But the meaningful use thing has to be printed out the same day, or it's within 72 hours. So that might work actually.
Yeah.
For them.
Yep.
But if you don't do it while they're there, then it would have to be mailed to the patient.
Mm-hmm. I do that sometimes. I also sometimes print them and don't give them to the patient, but I've printed them.
We've been told that's
not,
going to
I
be
know.
illegal, that they will have monitors who will call patients and sit in the waiting room and ask them, did you receive or did you receive an offer?
Right.
So I guess what you can do is offer it to the patient and say, you don't want this thing that has this sensitive information, right? Here's the shredder.
Yes,
We're putting
exactly.
it in the shredder.
Absolutely.
So I guess that's
Or you can offer to the patient and say, you can take this away, but just be aware of what's on it. So if you don't want your parents to see it, you should throw it in the trash or the shredder before you go. And tell them where the shredder
that
is.
works for us or in our clinic or in your practice, but if they're going to be going to other specialty providers and things in the institution, that won't take care of that.
Then that's where you're very careful about what you put in the problem list and where you have an expiration on your medications. The biggest one is birth control, because obviously you're not going to have an expiration on that. But how many patients do you think are on birth control and their parents don't know?
Lots.
Lots.
Yeah. And then you have all the side meds,
Yes.
autism.
But those the parents have to know about. So those you can't treat adolescents in this state anyway without parental consent for psych meds. So those they would need to know about.
Just want to be careful with time.
Yes.
We can go a little bit over because we started a little bit late.
Yep.
so
Okay. Thank you. Sorry. Go ahead. At what age?
Up to what age?
18.
So under 18.
parents have to consent for medications related. They can consent to other types of psychiatric care and mental health, but for medications, you need parental consent for psychiatric medications.
So should we be getting grades of information from every adolescent for them to give permission to their parents to be aware of issues? It's so different what we do. I mean, family therapy, treatment plan gets
Right.
signed by the parents. They know
Right.
exactly what we work.
No, I don't think you have to get consent because I think that the patient signing the treatment plan as well as the parents, so that I think that's implied. And in terms of psychiatric meds, they're allowed to know about that. So the time I do get consent is in my patients who are over 18, because technically if parents call up and they want information, we can't give them anything. So I do often say, as they're headed off to college or at their 18-year visit with the adolescent alone, I will say, you have an option to sign on for your parents to get information. Do you want to do that or not? And is there particular information that you don't want to share? And we have a form that allows them to check off whether they want all information shared or whether they don't want specific information related to STDs, et cetera, shared. But that comes up a lot with the kids away at college and the parents call and they want, something sent or, I've had.
Is that part of the electronic medical record, or you have that somewhere in a paper chart?
Well, so this is again probably an institutional thing. I send them to scan, and generally they get scanned into the chart, but then it also gets documented in a particular section on the front sheet of the patient, like what we call the snapshot. So it says parental consent signed on X date, and the medical records fills that in so that we know that.
Just about when you're actually, if you are giving a patient a prescription that they don't want their parent to know about, I get that question a lot. Are my parents going to find out about this prescription through the insurance? And I'm never really quite sure how to answer.
They don't get an explanation of benefits of the prescription itself unless they're using like Express Scripts or any sort of send away.
So if they go to the pharmacy and fill it themselves, they should be.
Yes, but the problem that they will run into is that they may not want to use the pharmacy where they go for other routine medications, because the pharmacy will have their name and their parents' information on file, and the birth control prescription will be ready. They'll call home and say it's ready. Or even I've had patients who parents come in to pick up a different medication. They'll say, like, oh, I have such and such as birth control. Here you go. Guess what?
Also, at the end of the year, the parents might get a printout of all the medications for taxes. The copay that the parents pay.
Yes.
And it lists prescription by prescription by prescription. Say, oh, you were taking every month. You were taking this.
I
You could ask the insurance company.
Yes.
They can call the patient. I think can call and say that they do not want their prescriptions to be printed out as.
Yes,
part
that's
of
right.
that.
That's right. And technically they shouldn't, because the adolescents paid the $10 for the copay and not the parents, so they shouldn't be claiming it anyway. But you're right. But the adolescents can actually call their insurance, and in fact, the reason I put this up here, I'm not advertising for Blue Cross Blue Shield, this is from actually Blue Cross Blue Shield, New Jersey, and they actually put out regular magazines for their patients that discuss confidentiality and consent on a regular basis, and they summarize in there EOBs and what to know about them. And there was a lawsuit, so they're all over it. They have laid out. They have it on their website too, what patients should know about EOBs. So sometimes you can even just print that and give it to the patient to say, here's what you need to know. Go ahead.
So to release medical records to parents, if they don't have any confidential information, do you still need the patient to consent?
Under 18, no. Over 18, yes.
Under 18,
Yes.
no.
Yes.
So it's
Yeah.
only
Confidential, yeah. So for any visit that I see, I have a standard thing that's at the top of the visit that says this is an adolescent clinic visit. There is some information in this record that's confidential. So those pages don't get released without patient consent or without consulting me, where I will say, well, actually there's no confidential information in there because there's nothing going on. But generally I'll actually contact the patient myself or have medical records contact them, or it depends on the scenario. So in terms of just getting back to billing, basically the way that I think about things with my patients is the first question I want to know is whether their parents know that they're there. If they don't know that they're there, then we talk about EOBs, and we talk about whether if their parents if they do get a summary in EOB, which is not that likely if it's for a confidential service, but if they do get it, will that be okay? Will they be able to handle it, et cetera? And if they won't, then we have a policy. If the parents know about the visit, I do make sure then that I just bill appropriately in terms of diagnosis. Although, again, as I said, sensitive diagnoses and testing is no longer allowed to be on an EOB. But, as I said, what I run into is that the lab may send a bill home. That's happened actually even at Boston Medical Center, where patients get free care because they weren't signed up, et cetera. So some things I don't know that you can completely prevent that. But if the parent does not have knowledge of the visit and I'm concerned about that, I do usually make a call to the lab to say, if you generate a bill and you're going to send it home, contact me first, which generally works. And occasionally we've just had to eat the cost of that particular test. We try not to, but we do occasionally. We probably don't have as many patients as you have that need that, so it's probably more of an issue for you guys than it is for me. But it's nice that we're able to do it. And then, as I said, I try to just make parents pretty aware from the get-go of what kind of testing we're going to do, what kind of bills they might get, what we're going to talk about, and I really encourage the kids to share with their parents. I recently had a patient who had a genital herpes outbreak, and she was having a lot of pain on urination and complaining to her parents about it, and they brought her in. She was in the room with me. I said, oh, this is a herpes outbreak. Well, it was very hard to then figure out how we were going to talk to her parents about it. And she and I talked about it for a long time. We just decided we were going to sit them down and tell them. And she wanted me to tell them without her there. And I said that would be fine. So I sat with them and I spoke with them. And it was good because they had a chance to process it before they went in, and then really were supportive of her and helpful. And I think that rather than, helping her make up a story, it helped to do that. And the outcome was, fairly smooth. I've had other times when the patient absolutely won't do that, and then we say, oh, they just have a urine infection, here's some medicines that will help it. But if you have a savvy person, you can't always get around that. That's right, exactly. In terms of resources, as I talked about, so the Adolescent Health Working Group has great protocols and toolkits. They have a behavioral health one, they have a nutrition one, they have a sexual health one, they have a consent and confidentiality specific to California, but it's actually got a lot of useful information in it. The National Alliance to Advance Adolescent Health is the organization that made the EOB change possible. They lobbied on behalf of adolescents to change that. NAHIC is also a great resource in terms of information about confidentiality to educate your patients, your parents, and yourself, and also just to know, when you get that irate parent in there, to know how you can kind of back yourself up and say, well, actually, I can technically do this. The Center for Adolescent Health and the Law is a fabulous resource. That's Abigail English's organization. I'm sure a lot of you know about that. Obviously, the Society for Adolescent Medicine, they actually do have some templates as well that are helpful, and which I haven't really glanced at their website until recently, and they actually have a fair amount of useful educational pieces for patients, particularly around consent and confidentiality and EOBs. And then Healthy Teen Network is also another organization that's done a lot in terms of consent and confidentiality and EOBs and helping educate teenagers about how to keep their health information confidential. So empower the patient. I mean, they're going to go on the internet and look at these things probably more than we are even. And that often helps. I mean, I learn things from them, and they give me ideas about how to manage the confidentiality issue, which is constant and ever-changing. What other questions? Any other comments? Because
It sounds like you've done a fabulous job in your private practice.
Yeah, I know.
Creating a system that's good for kids in this way.
we try. Sometimes it works.
I think it's extraordinary, and it was a really lovely way to end the day, so great job, Secretary.